welcome to everyone joining us today. As many of you will know, Canada's strategy for drugs for rare diseases was announced back in 2023 and earmarked $1.5 billion over a 3-year period. $1.4 billion of this money was put towards rare disease drugs, while the remaining funds went towards developing diagnostic tools, enhancing newborn screening, and improving the collection of real-world evidence and patient registries. So as we approach the end of this funding period in 2027, Canada stands at a critical juncture in how we support, treat, and care for those living with rare diseases. So today's session, Building on Progress, Charting the Future of Canada's Rare Disease Strategy, is focused on exploring the critical insights, challenges, and opportunities in advancing our national strategy. Our goal today is to look at what has been achieved under the current strategy, examine key data from a recent national study by CORD, showcase how digital and AI innovations are actively shortening the diagnostic odyssey, and identify the concrete policy barriers, or policy levers rather, systemic improvements and funding commitments needed as we approach the end of the 3-year commitment. So to help us unpack all of this, I am thrilled to be joined by an outstanding panel of leading experts and advocates. You can find their full bios online on the Longwoods event page, but please join me in welcoming Durhane Wong-Rieger, Dr. Cheryl Greenberg, Dr. Rebeccah Marsh, and Alexander White-Brown. Thank you all for being here. So while I will direct specific questions to individual panelists to guide our flow, I invite all of you to jump in and share your perspectives throughout our conversation. So let's dive in. Durhane, I'd like to start with you to set the stage on where we currently stand. We are approaching the end of the 3-year commitment for the National Strategy for Drugs for Rare Disease. So what is the single most positive impact we have seen in the environment as a result of this strategy?
Thank you very much, Karen, for the question. Thanks to Longwoods for the opportunity to be here and to talk about, certainly, I think, a very timely and important issue. And when you say what is the single most important, I think it's really easy in some respects. And I'll just preface by saying, we started petitioning Canada back in 2003, 2006, to have a Canadian strategy for rare diseases following, what Europeans and Americans are doing. 2015, we submitted in the House a rare disease strategy that we had built based on what UK was doing. And so it was quite a surprise to us, that suddenly, they seemed to listening, and they announced that in 2019 that we'd get $1 billion for rare disease. And then, of course, we had intervening election and intervening COVID and everything else. And then when it finally came, as you know, $1.5 billion. And I think what it really did for us is validate what we've been saying all along. And that is, it is critically important to treat patients living with rare diseases with the best possible treatment as soon as possible. And I think you'll hear a bit more when Rebeccah presents the survey that, this is, a buildup of what we've been doing. We did 2 surveys prior to that. And we finally were hearing that, yes, we need to treat patients. And importantly as well, what's included in there is that we also need to make sure there's screening and diagnosis. So some of the money's there. Really important to be able to register and know who the patients are. And it also included in there that we need to follow up with the patients to make sure that the drugs they're getting are working, et cetera. It wasn't everything, but really said, yes, rare disease treatment, rare disease patients, getting access as quickly as possible with support and right diagnosis is important. So, hopefully it's not a one-time deal, but it really did open up, I think, for the first time in Canada, that validation.
That's great. Thank you, Durhane. And I think it's really important that we acknowledge these positive steps and the momentum we've built. As you say, it's been built over many years, and it's important to highlight how critical it is we keep this going. So Dr. Greenberg, I'd love to hear from you on how to connect these strategic impacts at the front line of clinical care. So based on what Durhane just highlighted, what are you seeing in terms of the impact of this as a clinician who treats patients?
Well, first of all, I want to thank you very much for inviting me to participate in this panel. It's really an honor. Just from a point of view of those who do not know me, I've worked in the rare genetic disease space for over 50 years now. and I've seen, tremendous advances in, excuse me, both diagnosis and in therapies. And the rare disease strategy that has been put forward and the opportunities allowed with this 1.5 billion influx of money for rare diseases really resonates tremendously with me. But what I have seen, and over the past several years since the announcement of the rare disease strategy, is really, it really brings to foreground the bottlenecks. Where are the bottlenecks in the management of patients and their families with rare diseases? So for me, what I've taken from the strategy and working forward is, first of all, the bottlenecks to diagnose rare diseases. As a clinician, um, both the personnel is needed to work with families and to make sure that there's equitable access to all the diagnostic possibilities that really have developed tremendously over the past several years. Um, and so I've been working on enhancing the diagnostic strategy and access to new diagnostic modalities for the diagnosis of rare diseases. I've tried to address the gaps in the diagnostic strategy, and what we've done through the strategy is more involved in the screening and diagnostic subcommittee. Um, and really, for us, it's really acquiring the technology to do the state-of-the-art DNA sequencing, and that rapidly is changing. So, although we have personnel improvements, there's lots of outdated equipment that have to be replaced. And hopefully, the screening and diagnostic subcommittee that I work on is addressing how we can address the gaps and avoid the bottlenecks by improving instrumentation, improving training of the personnel to ensure uninterrupted continuity of diagnostic services and state-of-the-art services. I think I'll stop there and
Yeah,
carry
that's
on.
great. And clearly, the diagnostic odyssey is so foundational to the whole rare disease journey. And so all that work you're talking about and the equipment needed is a huge part of how we need to enhance patient care. So I'm curious if we were to just take a different angle on this, and if you were to put yourself in the shoes of the patients, what do you think your patients might say about the impact that this strategy has had on them?
Well, for a year, for me, right?
Yeah, from your
For
patient
me,
perspective.
as a clinician, and seeing families coming to us for diagnosis and potential treatment. But what I feel, regardless where you're practicing as a geneticist or as a provider for rare diseases, you have to manage expectations. Okay. There are roadblocks and bottlenecks all along the diagnostic odyssey. And in spite of the tremendous advances in the diagnosis and treatment, we have to manage expectations. At the same time, be an advocate as best as possible for patients with rare diseases, and that's a difficult balance. And there's often disappointments and with the reality of once you have a diagnosis, whether or not there is even an available treatment. So, advocacy as a clinician is a very, very important part of what I do and help patients on this journey.
Karen, can I just jump back in for half a second to respond to
Of
Cheryl?
course. Of course,
Yeah, I mean,
please
I
do.
know you wanted a bit more of a conversation as well. I think what Cheryl says is great. You asked me what was the most important good thing, and I really wanted to emphasize that. And I was happy to have Cheryl talk about some of the challenges because, as she says, what happened is we made treatments available, and all the drugs that are listed on that, common list that the drug strategy provided for, people were getting rapid access, but it was not equitable. Some of the drugs were not available in some of the provinces. But more importantly, as Cheryl indicated, we are not necessarily getting people diagnosed. that actually had access to treatment. And I remember asking some of the clinicians and even the companies that are bringing them in, given the fact that we've got these amazing therapies that have now been brought forth, what percentage of the patients in Canada do you think that are eligible for this? That you would know based on the estimates of what that population is, do you think are actually getting access, given the fact that it's already being funded? And I get this answer like 20%, 40%, that's maybe 60%. And what's the problem? As Cheryl says, we can't diagnose them. We can't find them. They're hidden in the system because we have not, at the same time as we've brought forth the drugs, and we can talk about this more, right? We have not also put in the pathways to screening and diagnosis to getting them to a specialist. They're there. But the fact is, we also have to make sure, right, that we're going to be able to provide access to all the people. And that's the crime. A lot of times, as Cheryl says, we diagnose somebody and we can't get them a treatment. Now I got a treatment, I can't find a patient.
Yeah, that's a great point. Dr. Greenberg, anything you wanted to say in response to that?
I guess from a practical point of view, what has been done, since the announcement of the $1.5 billion. So there's various strategies that have happened nationally. I've been to improve access to urgent needed therapies. As you know, from a national perspective, there's that private members bill of Marcus Pulowski, the member of parliament from Thunder Bay, who's working closely with Durhane and many others from a regulatory point of view to improve access to drugs that are not approved in Canada, but are approved in the United States and in Europe, to accelerate access through the Special Access Program in Health Canada, through a special private members bill that will help avoid some of this bottleneck in terms of access to drugs that are approved elsewhere. So I think from a regulatory point of view, regulatory reform and legislative reform is something that has been worked on tremendously over the past few years. And again, also through our screening and diagnostic work, updating outdated instrumentation to make sure patients have access to state-of-the-art equipment diagnosis, regardless of where you live in the country, should be a priority for the rare disease strategy.
And just one more quick comment, Karen.
Sure.
The challenge is that, if I can get the patient to Dr. Greenberg, that's a home run. My problem is that there are many patients out there, right, who, number one, are not going to get to Dr. Greenberg because they're a frontline physician or there's not the awareness that, this exists. There's also, as we know, patients who live very far away, et cetera. So, and there's not every one of these conditions, even the ones that have been approved for treatment and rapid treatment, right, have a access pathway that has been laid out. So as she says, we've been able to identify getting the drugs, the drugs are available. We can't always get them to the patient. So if we had more of Dr. Greenberg, it'd be easy. If we had Dr. Greenberg out there spread across the entire country, speaking the way she does in terms of her diseases, we'd be so far ahead. But we have not necessarily invested in that kind of a pre-strategy, right, before you get to the treatment.
Absolutely. So absolutely the pathways, the support system to really wrap around that whole ecosystem of patients and caregivers. If we set things up, we need to ensure the wraparound is there to get it there and the pull through. So I'm going to
Can I
move
just
us
add one
on.
thing? Can I just add
Sure.
one thing?
Yep.
There was somebody mentioned in the chat. I mean, there's so many groups of rare disorders, of which there's over 8,000 of them, that are not being addressed in Canada from a collective point of view, from a family point of view. And I think that's where the different genetic centers across Canada need to work together more. So if we're not seeing patients, let's say with congenital disorders like glycosylation, but we have a patient who's diagnosed, working with other centers collaboratively across Canada is a high priority of all the genetic centers and something we have to do a better job at.
Thank you. I completely agree. So to look at the burden that this community faces, we can also look at data. And we know the CORD study recently, or CORD recently commissioned the Institute of Health Economics to analyze data from an Ipsos survey conducted last year on the impact of rare disease in Canada. So, Rebeccah, I'm going to invite you to share with us insights from this study. And I am sure that everyone who's dialing in today is really keen to learn more about this. So we often talk about this diagnostic odyssey. It's been the topic of the first part of this panel. And can you share with me, what did the survey tell us about the cost of this diagnostic delay?
Yeah, absolutely. Thank you so much for this opportunity, as well to Longwoods to be part of this really important conversation. And we've started talking about some of these different elements that form the complexity and the web of challenges that can face individuals who are living with rare disease, as well as their families and their communities. And we're really fortunate that last year, CORD worked with Ipsos to run a national survey of individuals and caregivers in Canada to directly collect their experiences. So as you said, Karen, having this data is extremely important. Having data from those impacted directly is particularly important. And so I'm really thrilled to be able to share some of the insights from this survey. So it was conducted last year. There were 205 individuals who participated in this survey that asked a really broad range of questions across domains that included things that we're already talking about here around diagnostic journey, around access to care, around the impact on their daily lives, including time, including costs. There were 141 individuals living with rare disease who answered the survey. There were also 64 caregivers of individuals who answered the survey as well. And so just 3 highlights that we wanted to share, and please stay tuned, follow CORD and their work to see more of these results that come out as well. So the first thing we wanted to highlight was around the diagnostic journey that can be long and complicated. So of the respondents, 67%, so just over 2/3, experienced a diagnostic journey of over a year. Half of those almost experienced a diagnostic journey of greater than 5 years. And along this path, 44% reported at least one misdiagnosis, with the average of misdiagnoses being 5. And when we look at those whose journeys were over 5 years, those individuals and families reported 1.5 times the out-of-pocket costs for themselves. So really seeing the impacts of this diagnostic journey and the often twists and turns within it and the uncertainties, we can see the impact on the individuals and families themselves. And so moving into access to care, looking very broadly in the survey at the different impacts on individuals and families as well as the system. And so respondents to the survey, just over 1/3, so 35%, travel over 2 hours one way to access a specialist. So at least 4 hours every time they need to access specialist care. And of those that travel, half of them report that the accommodation costs that also go with that are $1,000 or more. And so we often see in data, which is extremely important, the number of visits that people have, but this is also looking beyond the number of those visits and looking what the individuals and families are doing around those visits in order to make them work. And so 84% of all of the respondents reported at least one challenge accessing an appropriate drug. And those without access to an appropriate therapy reported twice the out-of-pocket costs. So again, we look at costs to systems, but also looking at the costs to the individuals and families. Then looking more broadly at informal caregiving. So the survey looked at what primary caregivers as well as some secondary caregivers are supporting individuals living with rare disease. And so in the 205 responses, there were 129 primary caregivers that were identified and 66 secondary caregivers. And the survey was able to collect their experiences as well. And so looking here at just a couple highlights, 37%, so over 1/3 of these caregivers provide 4 or more hours of care per day. And just under a third of those, so 13% of all caregivers are providing 16 hours or more of care per day to individuals. And so what I think is especially important about this type of a survey is that we need all kinds of data in order to understand where best to invest as a society into improving care and services and supports for those especially living with the conditions and their families and their communities. And so really, I want to thank all of the respondents to the survey who took the time and shared generously about their experiences and contributed to this rich data set. There were over 50 different conditions that were represented in this sample size of 205 that also represented almost every territory and province in Canada. So it's really important to get the Canadian perspective, but most importantly, that of the individuals most impacted. Where are those opportunities, as Durhane identified? And it is now on us to use this data to help improve services and ultimately outcomes for all individuals and families in Canada.
Thank you, Rebeccah. I couldn't agree more. It's now on all of us to look at this and say, how do we create action out of this? So I would love to hear from you. What resonated with you the most out of this study? You've analyzed this intimately. You know these numbers inside out. What resonated with you the most?
I think what resonates for me the most is that as someone who has spent my career in analytics and data, in evaluation, in economic analysis, that there are often data, costs, and impact that are hidden. They aren't visible in the data sets that we commonly have. And so when we can see in these types of data sets, it's not just the number of visits to a specialist, it's what surrounds those individual visits. So it's the travel, it's the accommodation, it might be time off work. So it's the broader experiences and impacts, and the fact that we can get that data, that we have people who are willing to share generously that data as well, that we can then combine in. So really looking at, for example, the primary caregivers as well as second caregivers. We are looking at some of these families. 66 of the 205 respondents identified a primary and a secondary caregiver who are supporting daily within for this individual. And so being able to bring to light and put numbers to these I think is extremely important to these kind of conversations. And so how do we now integrate this with data that comes out of the systems and the healthcare data as well? How can we combine those to get a broader picture of the impacts and the costs? And then look at, okay, where might we need more supports? Where might these investments provide better outcomes for those who are impacted, as well as those, as Cheryl mentioned, who are also supporting them. So when we think about the 2-hour travel, there are also clinicians who are in those centers who are supporting patients who are needing to travel to them as well. So how can we now use this data to bring light to the diversity of the costs on this? And then just speaking of diversity as well, we always know that experiences differ. And I think this survey as well, in the 205 responses that have a lot of data and questions and domains that were explored within it, really showed ranges. So here you can see overall percentages, but each of these are also ranges. So an average of 5 misdiagnoses, there may be somebody who had up to, for example, in the survey, 40 of those as well. So also keeping in mind the richness of that data that reflects richness and diversity of experiences of individuals and families.
Thank you. So clearly this data is very compelling, and the fact that delayed diagnosis can lead to 2 times higher out-of-pocket costs amongst the households without access to the therapy, or 84% it reported at least one drug challenge. This shows that actually when we don't do anything, it costs the system too. So I'm going to now shift gears and want us to focus now a bit more on solutions. So one of the exciting ways we can address diagnostic delays and the economic burden is through innovation. So Alex, it's your turn. Can you share with us the approach CHEO has taken to help shorten the diagnostic odyssey with the Think Rare algorithm?
Thank you so much for having me, Karen. Very excited to be on a panel with these, 3 amazing individuals. And Rebeccah just very excellently outlined the significant impact that the diagnostic odyssey has, both financially and psychosocially for these patients. And I still find it extremely astonishing that in 2026, the diagnostic odyssey for individuals with rare disease, for a third of these individuals, nearly a third, is still over 5 years. We have advocated, we have all these new technologies. Still, a third of rare disease patients have a diagnostic odyssey lasting longer than 5 years. So I want to kind of rewind all the way back to 2019. And at that time, the Global Commission to End the Diagnostic Odyssey for Children with Rare Disease came out with many hypotheses for why the diagnostic odyssey for individuals with rare disease was so long. The fact that in Canada, we have a complex healthcare system. Rare diseases themselves are very complex. We had a shortage of geneticists. But one of the ones that they really focused on was the fact that there's minimal physician training on rare disease. That's to say that physicians outside of geneticists really don't have a lot of specialized training on recognizing rare disease. So at that time, the Global Commission made this recommendation to better equip these frontline providers with tools to identify these patients, to better refer them to genetics or other specialties to try and clarify their diagnosis. And around that same time, around 2019, 2020, a colleague of mine, his name is Ivan Terakov, and he's the Director of Research Informatics, AI, and Technology at CHEO. Him and the data warehouse team here at CHEO in Ottawa, our pediatric institution, were doing a bit of a roadshow. They were saying we have all of this great patient record data here at CHEO through our electronic medical record system that we've had for about 6 or 7 years at that time. We just feel like we could do more with this. We have a wealth of data. Let's do some good with it. So they went to all of our different departments, and that's when they met with myself and Dr. Kim Boycott in our genetics department. And at that time, Dr. Boycott was a part of the Global Commission and said, well, we've recognized that frontline providers need better tools. We, at that time, did some very simple math and figured out that we estimated that we were missing about 50 to 100 rare disease referrals to our genetics department roughly a year. So we thought, why don't we try and build an algorithm, a very simple AI-driven rule-based algorithm that could read through the electronic medical record data, so structured data, things like diagnosis codes, lab results, encounter visits to different specialties. Why don't we try and use that information to identify suspected undiagnosed rare disease patients and have them referred to our genetics clinic for appropriate testing. So we started off just by building our base algorithm. We put together some expert curated criteria. We ran it about 6 or 7 times on a cyclical basis, providing feedback and modifications. And 4 years later, in 2024, we had our first algorithm that we ran retrospectively. And then since then, we've actually been running this on a day-to-day basis, so prospectively. And since 2024, we've actually identified more than 100 rare disease patients who were previously undiagnosed. 43 of these patients have since been referred to our genetics clinic, and 21 have now received a clear diagnosis of the 30 who have received testing so far. And that's really how we've demonstrated the success of our algorithm and of our project. And actually, what's happening right now is since March of 2025, we've actually been running this as a clinical tool at CHEO. So we've taken an AI-based project from the research side. We've gone through the privacy, the ethics, all of those things to get this as a clinical product now being used kind of independently at CHEO, identifying patients in real time. And kind of going back to talking about what this means for the diagnostic odyssey, this has really been exemplified through a patient that we identified through a retrospective analysis in 2024 who was actually 17 years old when we found him. And you'll see coming up on the screen now actually a graphic of patient A's real-life diagnostic odyssey. And what you might notice first, your eyes might get drawn to the fact that this patient's diagnostic odyssey actually began before he was even born. So in 2006, this patient was identified to have 2 congenital heart defects prenatally. He would go 17 years seeing 8 different outpatient specialists across 153 outpatient visits. And what we don't see on this graphic are the days off of school, the days away from work for the parents, the costs of paying for parking. We just saw the information that Rebeccah gave us from patient and caregiver surveys that say 1.6 times the cost per year, out-of-pocket cost for patients where the diagnostic odyssey is more than 5 years. So you can imagine the cost of this family going through a 17-year diagnostic odyssey. And we were able to identify this patient at 17 years of age, and 6 months later, provide him his rare disease diagnosis of Syndrome-Hicks-Weiss syndrome. And it was actually his mother, when we were giving the results, who gave us a very interesting and very meaningful quote saying, why weren't we referred to you after he was born? We knew that there was something there. Why weren't we referred to you then? And although we can't go back in time and change that for this family, unfortunately, by running this prospectively on a day-to-day basis now, we're actually identifying patients as young as 3 months old. And when patients are getting a diagnosis that early or at any point, when we're ending the diagnostic odyssey, we can say that a clear diagnosis is the cornerstone for informed care, entry into clinical trials, treatment, insurance for the families that they have answers now. So a reassurance that, this wasn't their fault. And if you go and look up Think Rare, you'll see some amazing patient stories and some quotes from these families who have received these diagnoses after very long diagnostic odysseys saying, no more blaming ourselves, no more having to wonder why these things happen. So we can't put aside the emotional aspect of these diagnostic odysseys and what that has for these patients. So we're very happy to be running this at CHEO as an active clinical product. We're happy to announce that we're looking to move this more nationally and internationally as well.
Thank you, Alexander. And I sure hope you saw all those hands of applause going throughout as you're talking. You obviously have a lot of people cheering on your great work. Those 21 patients who've been diagnosed, I'm sure they and their families are thrilled because that shortening the diagnostic odyssey gives them the gift of time.
Can I add something?
Certainly.
I just want to interject because I think what Alexandre has presented is absolutely amazing. But when I look at that diagnostic odyssey of that patient over 17 years, that patient has seen specialists and subspecialists. Okay, these are pediatric trained specialists and subspecialists, and yet they didn't either have the tools or it wasn't available for them to think genetic, think rare. But if you go back even further, these are people who are already at the tertiary center. What about everybody that's in the community? And that's where I just want people to know that there are other strategies in addition to this wonderful one that was going to improve and lessen the diagnostic odyssey, and that's what we call mainstreaming. When people who are non-geneticists, have the ability and the tools to think about genetics when they see a patient in their office, whether it's in in a rural area or in an urgent area, and improve the diagnostic odyssey and lessen the wait times is by improving the training of family doctors, nurse practitioners, other care providers, and give them the tools when to suspect a genetic disorder, when to refer. And then once they refer, then they can hook into the algorithm that Alexander presented. And that's what's called mainstreaming. And there are a lot of centers who are giving family doctors and whether rural or urban, the tools, working with genetic counselors to really shorten that diagnostic odyssey as well.
That's fantastic advancement.
Do you mind, Karen, if I kind of respond to that quickly?
Certainly.
Just
And
just
then
to
we'll move on.
say,
Yeah.
yeah, so Dr. Greenberg, I think it's a very great point that these tools need to work together. So when we think about ThinkRare, it's not a one-stop shop. Mainstreaming actually goes very well together with ThinkRare. And the one thing that we've heard, so we've actually met with McMaster Children's Hospital in Hamilton, and also the Alberta Children's Hospital in Alberta, as well as Stollery Children's Hospital and other hospitals around Canada. And when we present this and they say, we really want it, but our wait lists are really long and we're adding to them. And so mainstreaming, again, is something that we have to use to minimize those wait lists. We can't not use something like ThinkRare because the wait lists are long. These patients still need to be recognized, but we need to use mainstreaming as a way to make sure that these patients are being identified and seen in a timely manner as well.
I mean, I totally agree, Alexandre. We have incorporated mainstreaming here in Manitoba, but for that to work, the primary care providers need to get support from genetic counselors and other health professionals to really to take ownership of and want to work with families with potentially rare diseases. So mainstreaming can work, but we need to provide the training for family doctors and nurse practitioners to really buy into it. Our surveys of our families who've been referred to us from a mainstreaming point of view is universally also very, very, very positive. It works. So combining mainstreaming and think rare is really important, are really important to move forward on this.
Wonderful. Thank you. So Durhane, I'm going to come back to you. We've heard about the data, the burden on the patients and the healthcare system, and what the diagnostic odyssey can look like for a patient. So I'd like to hear from your perspective what the study tells us in terms of where we should focus for future policy change.
Yes, thank you very much for all that brilliant discussion as well. I think what we recognize, court supports hundreds of rare diseases. I think the challenge as well is that what we're finding is that many of these diseases are becoming, even what we call ultra rare, extremely rare. And some of them may affect only a few families, even in the whole world, let alone in Canada. So, and it's great that we're talking about, the diagnostic odyssey and certainly the rare find is an amazing program which we are seeing being addressed across the country. I just had a conversation in the hallway yesterday, Alexander, with Genome Canada, and they're very keen to help us support, bringing it into other hospitals because of the great value to it. But we have to recognize, right? Not every rare disease is a genetic disease. And not all rare disease patients, even though a lot of them are children, are going to be diagnosed even in childhood because many may not be symptomatic. And when I'm looking at the amazing questions that are coming in, we also deal with, it's this early, the first step is getting earlier diagnosis, but it means that we have to have multiple strategies. I think what, Cheryl's talking about in terms of mainstreaming, et cetera. But again, we may be talking about a fairly limited scope in terms of rare diseases. How do we find rare diseases that are adult onset? You talk about something like acromegaly. You may not know it until you're much, much older. We talk about, SMA is great. You can do a genetic test early on and to identify, but there are other conditions that, some of the triglycerides and hemoglobinopathy, some of them will not be, even symptomatic until the patient is actually quite a bit older. So we need to have multiple strands in terms of addressing this diagnostic odyssey. And yes, newborn screening will help us a lot, but newborn screening in and of itself only addresses a very small portion of all of the even genetic rare diseases, right? Important, but we can't just say, okay, we're going to go down this stream. So I think what the survey has helped us see, and I think Rebeccah talked to some of that, is where are all the other possible places where people get stuck. And she only presented to us that top level of what the data were saying. But as you say, when we drilled down on it, we identified that there are many more patients that we have to be able to identify. And, I think this is something that, as we have this rare disease drug strategy, it provided drugs. But again, it only provided for a limited number of drugs. And there's so many more drugs that are coming through the innovative pipelines. So that's important. The second thing I think, as you've got here, and I think is really important, is that where patients get lost, even after they may be diagnosed. I think it's wonderful what Alex is saying. You find a patient through rare find, you hang on to them, you help guide them through the system. And I love the fact that, in speaking to Chio there, they take the patient, they try to identify the specialist, the site that they need to go. And in many cases, they do really get that supported care. In many other cases, even after a patient gets diagnosed, and we see that in many of the questions, they get lost. Nobody is guiding them. Nobody's actually helping them to get from even the diagnosis onto where's the right care you're getting. And even if they get access to, in this case, very importantly, a treatment, there may not be a treatment. And they may not be qualified for that treatment. And even if they qualify for that treatment, it may be very complex. And there's not necessarily somebody to guide them through that. In many cases, if they get into a pediatric center, they may have some care coordination from the pediatric center. What we often talk about is the big chasm between, that drop off. Patients, my son was one of the examples. Tremendous pediatric care all the way to he gets to 18. And it's like, okay, you're on your own. And I think that's what we need to do. We need to have the coordination. We had a brilliant presentation from adult, clinician dealing with adult SMA. Again, we think of SMA as a children's disease, and now we've got these great interventions, drugs that we can provide at birth. But, we have also adults that have not been diagnosed from birth, and they can't get access to treatment. And even once they, graduate from the pediatric side to adults, like, where's the coordination for that care? We have, in a few cases, we've seen great examples of what they call care coordinators. And these are in many countries, not Canada, there aren't what we call rare disease coordinator. You get diagnosed, you get assigned a coordinator, and you get somebody to help you, navigate through the many tests, through the many opportunities in terms of treatment. But we also know, as you say, in terms of the transition across, and I think this is part of what we're seeing in terms of even after a person gets access to sometimes the very best medicine, there's a lot of challenges. And as Rebeccah, showed, that there's a lot of care that still falls on the individual. I have to say, as, the needs change over time, right? Or as patients come into the system at different points of their disease, we've got to be able to assure that we can diagnose them appropriately, make sure that people do get access to treatment. And our system is not really very well set up to actually track a patient once they come into getting access to treatment. Even these very expensive drugs, and everybody agrees they're expensive, very worthwhile, but we don't do the best we can to make sure that the patients, they'll stay on the therapies. It's not the patients that's the problem. Their specialists are not the problem. We're not actually collecting the data to really be able to show how well it works. We're not collecting the data. Some of the people have written in the questions here, our data systems are not integrated across provinces. If I've got, only a handful of patients in each province who have the condition, even if they're getting access to the treatment, and I want to know what the impact is, I've got to be able to collect that data and to be able to integrate it across provinces, right? So again, this is what we need to focus on. So, we've got access to the drug. That's like that iceberg, tip of the iceberg, right? This is great. But what we know is that so much underneath it that actually makes it very difficult for us to get the best value of it. The other thing we don't have in this country, and many other countries do a much better job of it. I look at, some Scandinavian countries, the UK, Australia, especially Spain, where caregivers and where the family is treated. We often say, though we don't act on it, a rare disease does not affect a person, it affects a whole family. And what we see that effectively when we think about adult onset, like ALS is a great example, right? It's not a person that has, ALS. My husband, had Parkinson's disease. And then we would say over and over again, the patient doesn't have Parkinson's, the whole family has Parkinson's. And again, we don't have the wraparound to help do that. And it ends up, as Rebeccah is saying, the cost to the caregiver is tremendous. And we're looking at some of the economic costs, but what we also know is that behind those kinds of numbers in terms of finances, there's tremendous psychological, emotional, kinds of tolls that are, not evident. And, people can't go to work or people themselves just aren't well. And I think that's, again, something that we need to be able to invest in. And many of these diseases, as we know, are inherited in families. I will say my side point always on this caregivers, we know who the burden of the care falls on. 80% of the care falls to women. Women are always the ones that are most affected in rare diseases. And one of the things that we didn't show here, but we do know, is that, and it's in the data as well, Rebeccah, is that for rare diseases, a woman who has the same rare disease as a man will get diagnosed on average a year later. Now, why is that? And when we talk to women, we hear it. Yeah, it's just nobody believes them. Nobody wants to listen to them. Or they don't put themselves forward because they're too busy taking care of everybody else. So we have to look at those kinds of inequities and being able to address that as well. And of course, the care burden does fall onto parents, right? And in some cases where the core family may, in fact, separate because of a rare disease, it's often the mother who gets then to, take on the most of the care practices. So I think, we recognize that a lot of what we've seen in this survey and what we're addressing with the current rare disease drug strategy is that very tip of the iceberg, it's a very important part of the iceberg. But as we've also talked about, as Alex and Cheryl and others are talking about, if you can't get to the top of that iceberg where you're seen, nobody even knows you exist. You're submerged on the bottom there. So we've got to find a way of being able to lift everybody, to the point where, yes, I've got you've got a prize here, but if you can't get to it. And we also know, I think as many of the people are putting here, not every disease is included. We need to do a better job. And what this strategy has shown us, though, that if we can diagnose and treat, we actually do get, value back. So what does that suggest? It suggests that we actually should be able to provide more treatment. And treatment is often the gateway to getting the diagnosis, to improve the family care, to be able to provide better kind of treatment support all around. Sorry, I didn't mean to make this into a long lecture, but it really is. And the last point, though, is the most important. And I know this is Cheryl's favorite point because every time I speak with Cheryl, she's talking about, and that's equity.
Well,
And she's the one that also taught me a whole lot. Equity is not equality. Equity means that we give more and more is needed, right? And we have to make extraordinary efforts in order to make sure that those who are the most disadvantaged. Some people are talking about what about the people living in rural areas. It doesn't mean that okay, we'll open up the door and we'll provide a pathway for you. We have to really work at bringing them in. If people are, economics, we know. So social status has a lot to do with who gets diagnosed, who gets access to the care, even when it's there. And that's just from the point of view of health literacy, or who can actually free themselves up from the burden of daily care to be able to get to that specialist and to the care. Or as Cheryl, again, I hate to keep my Cheryl, it's one of the most important one, is that when you've got cultural differences, when you've got, ethnic differences, you've got to make that extraordinary move to bring that person into the care portfolio because they're not necessarily going to either recognize it or be very trusting of the system. So there's huge issues that are beyond just the cost of the medicine, getting access to it. Not everybody is eager to get a very, invasive kind of a treatment. You got to have a caregiver who's going to be able to help explain it and to support it along the way. So I think having this access to this drug strategy has been tremendous. What it's really done is highlight to us how very challenging and slippery it is to get to that top where the care is, and how much, much more of the system we need to be addressing. And this is where I put in my pitch. This is why we need to have phase 2 of this strategy. When it came in, it was a 3-year strategy, and it was promised that this would be an annual allocation. And we have been talking with the government, we're talking to the federal government, talking to Health Canada, we need phase 2. But we don't need phase 2 to look like phase 1. We got to learn from phase 1. We got to do better from here. And the rest of this year, we're actually going to be we're going to host a series of webinars. Probably not as good as Longwoods webinars, unless Longwoods wants to come in and help us again. But we are going to host a series of cohort webinars that are going to discuss the next steps that we want to talk about. And the most important thing we do want to talk about is provincial readiness. Somebody wrote in here, how come only Quebec has a rare disease strategy? And good point. They're the ones that have the plan. So what we're going to do for whoever, wrote in that, who wants to help, we're going to assess each province and see how ready they are. And maybe Quebec is a good benchmark. It's probably not perfect either. How well is each province doing on the kinds of issues, right? So we're going to institute that coming up, and we're hoping we can use the rest of this year of this strategy to put us in a position to make the real case for an extension, for an ongoing, extension of the strategy, and to make sure that it's going to provide us and be directed towards the whole host of things that we talked about here.
Thank you, Durhane. And you gave us a great segue into our next section, which is really our call to action. So there are lots of questions coming in. We have lots of so I want to make sure we get there because I'm sure people want to have their question answered. So in summary, we've heard Durhane's call to action. I want in one sentence, 30 seconds, if each of, I'll start with you, Alex. What would be the key message or action you want people to take away from our discussion today?
Not forgetting that first piece. We've heard during Dr. Greenberg, Rebeccah mentioned the importance of the diagnostic odyssey, all these treatments, all the things that are happening, but we have to get these patients through the door. We have to get them seen. We have to get them diagnosed. And I'm actually going to steal something I hear Durhane say very often when I go to court conferences, is that there's still work to do. And from Think Rare, there's still work to do, and we're going to continue to do it.
Thank you. Dr. Greenberg.
Well, I'm learning a lot and would like to address some of the questions in the chat. But I think,
and we'll come to the chat in a second.
Yeah, but I think my one take-home message is not one size fits all. That there's different strategies that are needed to address both the gaps in the diagnostic odyssey, the unique needs of some of our special populations in Canada, making sure that there's equitable access to whatever advances have in diagnosis and treatment, and to ensure that patients as partners their voices are heard from at every step towards the next strategy. Yeah.
Thank you. And Rebeccah, over to you.
Yeah, thank you. And it really builds on those messages as well in using data as much as possible to inform our decisions around policy and practice, and using especially data that comes from the patients themselves, involving them and their data in these solutions, in strategies, and in our innovation. And so using data sets like that from the CORD survey, combining it with other data sets that are being collected nationally by Canadian Institute for Health Information, by Canada's Drug Agency, pulling all this together to make the best decisions possible, and then tracking that data over time. Cross-sectional is important, longitudinal data as well, so that we know, are we making an impact and enough of one?
Thank you. Those are great takeaways for all of the participants today. And Rebeccah, I'm going to continue with you and raise a question that was in the chat. So how complete and analysis ready are Canadian administrative data sets for outcomes research, and where are the biggest gaps? Example, outpatient prescribing, labs, oncology staging, patient-reported outcomes. We need better access to data.
So we need better access to data, we need better data and more data, but I always say as well, we need to make better use of the data that we already have. We collect a lot of data across systems, especially how can we leverage that? I will also shout out those working in systems, who are the clinicians, who are the managers and the policymakers. We know they use data every single day. And that for them, that is fit for purpose. So for us, it's also in broader conversations, what does that fit for purpose data look like? How do we trust the data that we have, because we are using it every single day. And often conversations are around, is the data good enough, in the quality of the data? And it's really around, what is that fit for purpose? How can we do our analysis in a way that can best reflect what the data is saying and what it is not saying, and then using that within these decisions. So I did shout out, and I do want to say that there are national organizations that are making intentional efforts to support national data as well in this and to collect across it. So CIHI, Canadian Institute for Health Information, does have an initiative focused on data from across provinces in the rare disease space. So visiting that, talking to them, working with them on how we can better use it. Canada's Drug Agency, which is looking at patient registries, so improving the patient data. What does standardization look like for these types of registries and that data, as well as was mentioned in the chat, real world evidence? How can we better use the data that we have in the real world as we are accessing treatments and innovations? How can we use that data to feed back in more of a learning and an adaptive loop in our decision making?
Great, thank you. And I'm just going to move us over to Alexander. There's one here for you, congratulating on the initiative, and then asking, how do you see the process change to systems or processes gain adoption with other institutions and patients in the future?
Two things that we're doing right now. So this was something that was made by CHIO for CHIO, embedded within our electronic medical record system at CHIO called Epic. And it was really kind of baked into our system. And one of the things we've been working on in the last year has been taking it out of there and building it into an application to make it what we call EMR agnostic, so that this is something that can work at any pediatric or hopefully eventually adult hospital institution, so that this is something we can spread nationally across all hospitals that can use not just the structured data, so this comes to point number 2, but also unstructured data. So I mentioned that we were using things like diagnosis codes and encounter visits, things that are very easy for us to pull, very easy data points. But what we're trying to do now is use more advanced AI called large language models that can read through the encounter visit notes that help us take out some of those false positives and help us capture more patients that were missed before. So we're trying to use different techniques to make this more accessible. And we're also trying to pair and find partners through strategic partners, through industry, through government, to make sure that this is something that is free for all institutions within Canada, so that there are no barriers to adoption. The goal of Thinker is to make sure that it's helping the rare disease community first and foremost at all times. So we're not trying to add more barriers by making this something that needs to be paid for. It's something that through strategic partnerships, we're allowing hospitals to adopt without cost, and just helping them go through that process to adopt it at their institution.
That's great. And we have literally 1 minute left. So what I will say, there are some in the chat, and if some of the panelists want to answer them online, that is great. We can hopefully answer those questions that way through the Q&A. And I just want to take this time to say my sincere thanks to all of these incredible panelists, Durhane, Dr. Greenberg, Rebeccah, Alexander, for sharing your expertise and passion with us today. And thank you to everyone in our audience for attending and prioritizing such an important topic, and for your engagement in the chat and the Q&A. And to the millions of Canadian families affected by rare disease, they rely on your collective advocacy to ensure we don't just pause at the end of this 3-year commitment, but that we actually build on this progress for a healthier, more equitable, sustainable future. So thank you to Longwoods for hosting us. I wish you all a wonderful weekend. And for those who are going to turn their attention to soccer, let's cheer on Team Canada. Thank you, everyone.
And thank you to Karen. A fantastic job moderating this conversation. Just very quickly, as everybody gets ready to go, your chat and your Q&A will be forwarded to the planning committee, and there may be future opportunities for them to address them. Thank you, and have a wonderful day. Bye-bye.
Thank you.
Thanks very much, everyone.